Good evening. Thank you so much for joining me this evening to talk to you about travel medicine, a little bit of an update around some things that are happening in travel medicine at the moment, but also to talk to you a little bit about postgraduate study and our travel medicine qualifications at the University of Otago. Thank you very much again. So let's get started. So the outline, what we're planning to do tonight is a little bit of a travel medicine update, looking at a general approach to the travel vaccination, looking at dengue, chikungunya, yellow fever epidemiology, and at the new vaccines that now are available for dengue and chikungunya. And then a few minutes talking about rabies vaccine schedules and when to recommend typhoid vaccine. And then I'll spend a bit of time at the end talking about our postgraduate qualifications and why I'd love to see you come and study with us if you haven't already done some of our papers. You please feel free at any time during the presentation to post your questions or any points of discussion into the Q&A box. And if for some reason you can't see the Q&A box, then just tick on that more circle at the end of the bar and you should find Q&A in there. And I'll leave all the questions and discussions until the end of the presentation. So talking about vaccinations for travel, we have often used this framework. We talk about the 3 R's. There are those vaccines that are routine, there are those that are required, and there are those that are recommended for travel. The routine vaccines are those that are on the national immunisation schedule, so the childhood vaccines, but also those that are recommended for adults routinely, influenza and shingles, but also those adult boosters that we need to give from time to time, and then maybe some at special at-risk groups may be funded or recommended, other vaccines funded or recommended. Then there may be vaccines that are required when we're travelling, which could be, a lot of this is around yellow fever, but also meningococcal is required for some and polio to enter some countries, but more importantly to exit some countries, or will be asked on exiting some countries. And then recommended for travel, hepatitis A, typhoid, Japanese encephalitis, rabies, and all those other ones. But increasingly, while this is a really good framework to talk about vaccines pre-travel, actually every vaccine is a travel vaccine. If we're up to date with our routine vaccines, we're going to be protected against those diseases, not only at home, but while we travel. And in this division between vaccines that are recommended for travel or required for travel or routine vaccines, there's a huge overlap. And there will be many vaccines that are routine, but we would also recommend them for travel. And there are some that are recommended, but also required, for example, yellow fever. But when we talk about our routine vaccines, they are all useful for travel. And I think this has been brought into quite become very apparent recently. I'm going to show this graph a few times during tonight's talk. This is the so-called Stephanogram. Prof. Stefan Robert Stefan puts this together every few years and then updates it. And it's a best estimate. It's only an estimate because these are based, we don't have fantastic studies or data on all of these, but it's a best estimate for a risk per month of travel in an unvaccinated traveller. And you can see that the 2 top diseases there are COVID and influenza. Vaccine preventable diseases, vaccines that we would assume, we usually think of as routine vaccines, not travel vaccines. And I think this has become even more important recently with the worldwide increase in measles outbreaks globally. And I'm sure we're all very aware of the messaging that's coming through to our practices from Te Whatu Ora, that we have to be very mindful of measles and mosquitoes when travelling overseas, that we are at risk, high risk of a measles outbreak. Globally, there are many countries that are currently experiencing outbreaks. including Australia, many countries in Southeast Asia, United States, Canada, and the United Kingdom. And our recent outbreaks in New Zealand have, almost all of them, have been linked to people bringing, non-immune travellers bringing the disease back from overseas. And of course, with the outbreak 2019 in Samoa, it was an infectious person, an unvaccinated New Zealander who introduced it into Samoa. So really important that we make sure that all our travellers are up to date with, are covered for measles. Those born before 1969 are assumed to have naturally acquired immunity, and anyone born between 1969 and 2004, which is the date before we went to the 2 doses at 12 months, 15 months, sorry, and 5 years. Many of those people would only have had a single measles vaccine, measles containing vaccine. So to get optimal coverage, they need to have two. So make sure they get a second MMR. And if they're already covered, it's not going to be harmful. And of course, everyone, all our younger travellers, we want to make sure that they're up to date with their 2 MMRs. And remember, the New Zealand Immunisation Handbook does say that we can give a 0 dose, sort of first dose of MMR, down to 4 months of age if they're going into an outbreak situation or at high risk when they're travelling. And of course, that doesn't count, so they still need 2 more doses after 12 months of age. So don't forget measles. So the pre-travel consultation is an opportunity to ensure that all travellers are up to date with the New Zealand immunisation schedule, and it will include covering those potential gaps and for example, at the moment regarding measles. The planned travel, and I often do find this with my travellers, that the planned travel is often the incentive that they need to receive those funded, recommended, and sometimes unfunded recommended vaccines. They just haven't got around to getting that influenza or that COVID booster. And when I talk to them about how important this is to be covered during travel, they say, well, yes, that makes good sense. And finally, the travel's been the thing that's pushed them to go and get those vaccines. There may also be a non-scheduled booster of what we think of as a routine vaccine pre-travel, for example, tetanus or polio. And then there are some travellers who might benefit from a primary series of what we consider a routine vaccine pre-travel, for example, hepatitis B in older adults. They wouldn't have received hepatitis B because they weren't, it wasn't on the schedule when they were children growing up, but as adults, they may benefit from it. And I encourage you all, the International Society of Travel Medicine has put together these really interesting and fun podcasts. It's free. You don't have to be members of the society. You just find them on YouTube. And and very recently, they have done a podcast on exactly this topic, the Traveller's Shield, that every vaccine is a travel vaccine. So enjoy those podcasts. There's also been a very recent one on altitude illness, which will be really interesting too. So now I was going to do a little bit of an update around arboviruses. So these are viruses that are transmitted to human beings through the bite of an insect. And I was just going to concentrate on dengue, chikungunya, and yellow fever in some recent updates. There are many, many other arboviruses. And I haven't put this map up to frighten you all, but just to show this, and this is just a map, a global map of many of the arboviruses that impact in human beings. You'll see that New Zealand is very lucky that we don't have any, along with Chile and Greenland and northern Canada and parts of Scandinavia. But really, every traveller, no matter where they travel, virtually no matter where they travel in the world, should do their best to avoid insect bites, because unlike New Zealand, where we don't have any diseases that can be transmitted through mosquito bites, in most other countries in the world, and it's not just mosquitoes, but it's also ticks and sandflies and other insects. But in most other countries, not only can the bite be harmful and be a nuisance in itself, it can also transmit disease. So make sure, and you'll see that a lot of Europe there is is coloured in for tick-borne encephalitis, but also there's some this season, I'll show you in a minute in the map, there's been some local transmission of chikungunya now in France and Italy. So even travellers to Europe need to think about avoiding insect bites as well. So what's been happening with dengue? So dengue is on the increase, and undeniably, just look at that graph. Look at the numbers in 2024 compared to 2023. So this published was this study was published very recently. So the epidemic worsened in 2024, 14 million cases and 9,000 deaths reported globally. But most importantly, the authors came to the conclusion that currently this is the world's fastest spreading mosquito-borne disease, with 14.1 million cases in 2024. But the important point being that 14.1 million cases in 2024 represented a doubling of cases compared to 2023. So in 1 year, the number of cases had doubled. Now, dengue does do this. It goes in waves around the world, but we've never had an outbreak this big. And it's a 12-fold increase over 2014. So the trend is certainly we're seeing more dengue. And of course, there's a massive underreporting of cases. What's driving this is urbanisation. It's global warming and it's globalization. It's the vector and the virus moving around the globe in people and in mosquitoes. This has been driven primarily by cases in the Americas, so Central and South America, and the lower parts of North America as well. Whereas traditionally, dengue outbreaks have very much been driven by large numbers in Southeast Asia. That was different in the most recent and ongoing outbreaks. But importantly, on the bottom right-hand side, you'll see there the Western Pacific region, which does include the Pacific Islands, but also parts of Asia. And although the numbers aren't as big because it's not as big a bigger population, this is very important because this is where most New Zealanders catch dengue. So if we look at the dengue fever notifications by year, so that dropped dramatically, of course, during COVID because the borders were closed. 2022 was very quiet, 23, but 2024, 124 cases, so not that many cases again, but up about where we were about 2016, 13. 280 cases this year so far to the end of August. So we're back up where we have been the highest most recently, and we've still got a few months of the year to go. But what is interesting, of course, if you look at where we're catching those cases, so in August there were 70 cases. 48 were in travellers returning from Samoa, 14 from the Cook Islands, 5 from Fiji, and 1 each from Indonesia, Maldives, and Tonga. So what happens in the Pacific is really important for where New Zealanders catch a lot of these vector-borne diseases. So we've all been urged to be on the lookout for dengue in our returning travellers, and to make sure that we're telling our travellers into the Pacific, but really everywhere in the world, to be vigilant about mosquito bites. So how can we prevent dengue? Is all about mosquito avoidance, remembering the mosquitoes that transmit dengue are day feeders, day biters, using plenty of insect repellents. I've put DEET, there are others, picaridin and oil of lemon eucalyptus, but it's the DEET-containing compounds that have been around the longest and have the best safety profile. And we know they work, but people do need to reapply them, especially if they've been swimming or if it's a very humid environment and they've been sweating a lot. And it needs to be tropical strength, a good 20 to 30% minimum strength. Protective clothing, the more of your skin you can cover up with clothing, the less you need to put repellent on. Mosquito nets, while they're really important in preventing malaria, which is transmitted by a night-biting mosquito, it is less important for preventing dengue, except perhaps for small children if they're sleeping under nets during the day. You can also soak your clothing in permethrin, the insecticide, and if you are going to be sleeping under nets, then soaking them in permethrin helps as well. If you have the ability, you can remove breeding sites and stagnant water, so sites where the mosquitoes will breed, and rubbish especially. But they're also indoor feeders, so they like dark areas. So make sure you're spraying closets and bathrooms and under beds and behind curtains. Management is symptomatic and supportive. There are 2 vaccines that have been approved. Only one of them remains available globally, and that's Qdenga. Dengvaxia was the first dengue vaccine, but production has now ceased. And Qdenga, although it's licensed in a number of countries, it's not yet approved for use in New Zealand. If you want to have an in-depth look at these 2 vaccines and the pros and cons and the efficacy data and then read the World Health Organization position paper. So Qdenga is a live attenuated vaccine. It's built on a dengue serotype 2 backbone, but it contains antigens of all 4 dengue virus serotypes. And the schedule is 2 doses intramuscularly at day 0 and then 3 months. It's a genetically modified live virus, the vaccine virus, so it does need an exemption from the New Zealand Environmental Protection Agency before it can be brought into New Zealand. And I've spoken to the producers, Takeda, and they're currently concentrating their efforts on getting it registered in Australia, registered for use in Australia. And we're not a big market, so they don't have any immediate plans to bring it into New Zealand. But it's still useful for us to know about it because we may be seeing travellers who have been vaccinated against this in other countries, and hopefully we will have access to it. And so the vaccine efficacy against virologically confirmed dengue overall is 61.2%. So not 100%, but that's okay, it's pretty good. But what you can see from here is that the vaccine efficacy is far better in those who are seropositive, so those who have had dengue sometime in the past. So if you've had dengue in the past and you get vaccinated, then you've got good protection against all 4 serotypes of dengue. And particularly high against dengue type 2, which isn't surprising because it's built on the dengue 2. That's the backbone of the vaccine. If someone has not had had dengue in the past, then the overall vaccine efficacy does drop. But most importantly, you'll see it gives no protection against dengue type 3 and dengue type 4, serotype 4. That's largely because there wasn't a lot of dengue 3 and 4 circulating at the time of these studies, so we really don't know how effective and how much protection they're going to give you against those serotypes. If we then look at vaccine efficacy where the end point was hospitalization, then the vaccine efficacy is even better. It's over 80, it's 84%. And again, it's better in the seropositives at 85%, 85.9%, sorry, compared to seronegatives at 79.3%. But again, we don't know how well this works in serotype 3 and 4. So in a summary, this is a good vaccine. It offers pretty good protection overall, but especially against severe dengue and hospitalizations, which is great. But we still have very limited vaccine efficacy data regarding serotype 3 and 4, and seropositives get a much better and a broader response, protection against all 4 serotypes. I haven't shown you the data here, but a single dose does give good short-term protection, which raises the possibility of just giving a single dose pre-travel because lots of travellers are not going to present 3 months pre-travel to complete that primary series. There is a theoretical concern remaining regarding what we call antibody-dependent enhancement. And if that occurs, it leads to a greater risk of severe dengue with a second infection in those who received the vaccine if they had not had dengue, if they had not had dengue in the past. And this was the real concern with Dengvaxia, with the first dengue vaccine. If it was given to people who'd not had dengue in the past, they were at much higher risk of getting severe dengue if they got breakthrough infection post-vaccination, because effectively the vaccine was the priming the first infection. And we know that in the natural world that it's usually your second infection with dengue that causes severe disease. Now, there have been no safety signals with Qdenga to suggest that this is a problem, but the theoretical risk does remain. So many authorities are saying that when it comes to using this in travellers, it's those with a history of dengue who are returning to a dengue endemic region, especially if they're going for prolonged or repeated visits, who are the ones who are most likely going to benefit from this vaccine. Now, I know this is a really busy table, and I do apologise, but it was really just looking at the different countries where this vaccine is licensed or approved for use, and what the guidelines are, the local guidelines are regarding use of the vaccine. And they're all pretty consistent when it comes to if somebody has had dengue in the past, is this a good vaccine to give? And the answer in all the countries is yes. But if you go over to that fourth column, the pre-vaccination screening, what they aren't or haven't come to an agreement on, or they have different approaches, is how do we know whether or not they've had previous dengue? Do we go on history alone? Do they have to have a serological positive test? A lot of the guidelines don't actually say anything, so there's dispute there. And the other area where there isn't uniformity or agreement yet is, should this vaccine be used in those people who have never had dengue because of that theoretical risk of severe disease if they got breakthrough disease? And you can see that some say the benefits is lower, or you can consider it. Others say you definitely shouldn't be giving it unless you know they've had dengue in the past, and others say it's perfectly all right. So a little theme that's going to come through here, and you'll see, I'll repeat it when I come to my discussion around chikungunya, is though even though we often feel that we miss out on things because we're a very small market at the end of a very long supply chain. But I think at least by the time we do get access to this vaccine, we're going to have some better guidelines and understanding and more experience from these other countries, so that we can be better informed about what travellers are going to benefit best from them. So yellow fever epidemiology, just a few slides here, and again, bit of a theme coming across here in the Americas. So South America here, we've seen quite a blip in cases in 2024 and 2025. 335 cases, 142 deaths. I know that doesn't sound like much, but we know when the reported cases are probably only the tip of the iceberg. And in many of these countries, there's quite high vaccination rates, so many people are protected through vaccination. But you can see that towards here at the end of 2024 into early 2025, we saw this peak. It is dropping off now, but what was interesting in these cases, and here's the 2023 is the yellow dots, you can see where there was the concentration. 2024 we saw increased numbers, in 2025 increased numbers again. And what was interesting here was there was quite a cluster in outside the Amazon here in Sao Paulo state in Brazil, and also in parts of Colombia outside the Amazon, so outside the region where we have traditionally seen yellow fever. So in 2024, the human cases were mainly in the Amazon region, in Bolivia, Brazil, Colombia, Guyana, and Peru. But the 2025 cases were outside the Amazon. And although where it occurred in Brazil was already in the designated yellow fever zone, the ones in Colombia and some of the other cases were in outside the traditional yellow fever risk map. So the CDC put out this map earlier this year where they're suggesting that the yellow fever risk map, or the vaccination map, should include areas outside so extending the map to include those red areas. There's still a lot of debate about exactly where that is, and you can see that it's very close to Cuzco and Machu Picchu. Nobody is saying at the moment that we should be vaccinating our travellers going to Machu Picchu, but I think it's a matter of watching the space and seeing what's happening here. But I think the message to us is that there is increasing activity of yellow fever, and the distribution seems to be spreading, so we may soon see the map being widened yet again. So then chikungunya, so 2025, we've seen this huge or significant resurgence, not in all countries, but particularly in the Indian Ocean. So between the 1st of January and 30th of September of this year, 445,000 cases of suspected and confirmed chikungunya virus diseases were reported globally from over 40 countries. And if you go to the European CDC, I always like their resources on chikungunya, because they, as I said before, there are countries now where they've got competent vectors and they're starting to see small outbreaks locally in some European countries being seeded by people coming from outbreak areas. So they've got a good update there on what's happening in the Americas and Asia and Africa. And basically, this resurgence is again the Americas. So we see Brazil, in Argentina, and Paraguay, Uruguay, India as well, parts of Africa. But you see there those cases reported in France and in Italy, and quite a large outbreak in China as well. But the two that they've had to put here over on the side, it's really been the islands in the Indian Ocean that have taken the brunt of this. And so Reunion and Mayotte, very large numbers coming out of those regions where there was a big outbreak about 10 years ago, and the thinking is that you have a new cohort of non-immune younger people, and the disease is taking hold again. So 54,000 cases in Reunion. And of course, the Reunion and Mayotte are seeding the outbreaks, particularly in France, because of the close association in travel. So chikungunya prevention is exactly the same. It's the same mosquito as transmits dengue. And there are two vaccines. They have been approved in the USA, the UK, and the EU. And I think it's Ixchiq is how you say the first one, and Vimkunya. And they're very new vaccines, especially the Vimkunya, the second one. So both of them have been, what's important to realize with these vaccines is they've both been approved on the basis of there being no safety signals in the studies, but it's all immunogenicity data. There's no real world data on how much chikungunya these vaccines actually prevent. So there's a presumed seroprotection based on an antibody titer, which is a reasonable one because it was in animal models, it worked. And there's no long-term immunogenicity data. So we don't have vaccine efficacy or effectiveness data to date, but it'll come out in the post-marketing period. The other thing that we're concerned about is Ixchiq, which is a live attenuated vaccine Safety concerns were raised in May 2025. There had been one death due to encephalitis attributed to the vaccine and 20 serious adverse events. It was predominantly in older persons, and in all the countries where it was approved for use and licensed, they placed a temporary pause on using this vaccine in older persons. Some chose a cutoff of 60 years, some 65 years. And then after that, there were four further serious adverse events reported, and they got a much better feel for the prevalence of adverse events because they were rolling out thousands, tens of thousands of the doses of this vaccine into the Indian Ocean islands to try and bring the outback under control. So as a result of that, in the USA, which is always a lot more conservative when it comes to harm to patients, they've suspended licensing as of August of this year. So you can no longer use IXCHIQ in the USA. On the other hand, the EU lifted its pause on use in older persons and said, well, yes, there is an increased risk, but it's not a huge increased risk. And if the risk of chikungunya outweighs the risk of the vaccine, it's worthwhile. The UK has retained, it still can be used, but it's retained its recommendation that it only be used in those under 60 years of age. And interestingly, they've added that a history of thymus disease or thymectomy is a precaution of use. And those of you who are yellow fever vaccinators will recognize that a history of thymus disease or thymectomy is considered by many to be a contraindication to giving the yellow fever vaccine. And the thinking is that you get an overwhelming vaccine viremia, which because of the reduction in thymus activity. So these are the two vaccines. So IXCHIQ is the a live attenuated vaccine, and the other is a virus-like particle adjuvanted, so a non-live vaccine. They're both one dose, single IM dose, which is useful. Slightly different cutoff ages, but they're not children. They're not vaccines for children less than 12 years of age. With the live attenuated vaccine, there's no data in those over 65 years of age. But in the Vicuma, there is some data in older adults, and they had similar seroprotection rates to the younger cohorts. Seroprotection rates looking good, both 90 or 98.9 and 96.6, but we don't have data yet in pregnancy. And the recommendations generally are that they should be used in travellers who are going to current outbreaks, and consider it to long-term travellers who may not be going into a known outbreak situation but could be exposed. So again, so if I go back to that, it will be good. Eventually, we hope we'll have access to these vaccines in New Zealand, and by the time they get here, hopefully we'll have some good, clear guidelines around when and how to use them. So a summary about the arboviruses. 2024, 2025, we've seen unprecedented number of dengue infections, primarily in the Americas, but very relevant to us, also in the Pacific. Yellow fever, increasing documented cases in South America, and some are outside the previous known or accepted range. And chikungunya, a resurgence in a number of countries, and seeding of local transmission into parts of Europe. So make sure all your travellers are doing their best to not get bitten by mosquitoes. So I was going to spend just a minute or two on rabies. And this is the map that the World Health Organization put out, I think it's 2019. Sorry, I've got my, 2018. And it includes both what we think of as terrestrial rabies, so that's classic canine dog rabies, and countries that had bat rabies. And if countries were bat rabies alone or bat rabies and they had good vaccination programs in place so that there was no rabies in domesticated animals, then they were low risk and would say no risk, no pre-exposure recommended. And then through to those dark red, the high risk countries where it's in domesticated dogs and potentially into cats. And we know in many of these countries also monkeys can transmit. Then you would recommend pre-exposure vaccination for travelers. And I mean, that's very useful, but I do like, this is another a study that's come out since then. And sorry, the map hasn't projected really well, but I do encourage you all to look up this paper. And is a country classification system to inform rabies prevention guidelines and regulations. And what they did is they looked at the existence of rabies, both bat rabies and canine or terrestrial rabies, but then they overlaid on that also the availability of pre and post-exposure prophylaxis. Post-exposure prophylaxis. So we had those. So category 4 are the Lassa-free countries like New Zealand, and there aren't many of us, but then the category 3 would be considered low risk, and post-exposure prophylaxis is available. So they would be countries where you would be less likely to recommend pre-exposure prophylaxis. There will be some individuals traveling to those countries who may still benefit from it, and certainly if they're at occupational risk, but generally they wouldn't require pre-exposure prophylaxis. Then you've got the category 2, where there's a high to moderate risk of exposure because it's in domesticated animals, but post-exposure prophylaxis is readily available or reasonably readily available. And you can see increasingly now countries in Asia are considered, so Vietnam and Thailand and Malaysia and South Africa in Africa and in Brazil, saying that post-exposure prophylaxis is available. That again, many travelers to those countries may still choose to get pre-exposure vaccination, because even if post-exposure prophylaxis is available in country, it's still going to impact on their trip. So I would still say many of those would benefit from pre-exposure prophylaxis, but certainly those in those very high, that browny color, really, really dark color, where there's both a high or moderate risk of rabies exposure because it's in domesticated animals, and post-exposure prophylaxis is limited. So I think that's a really handy little picture that you can use to educate your travelers as well. So we come back to the stephanogram again, and the risk of dying from rabies, travelers dying from rabies, is very, very low, 1 in a million. And it's estimated 2 to 3 people per million annually, globally, travelers, dying of rabies. But when we're vaccinating our travelers pre-travel, we're protecting them against the animal, what to do in the case they have an animal bite, because of course with a disease that has a close to 100% case fatality rate, you want to treat any potential bite as if it was a known bite. So World Health Organization brought out a rabies position paper in 2018, and and there were a number of other things that recommended, but the main impact on our travelers was that they recommended new pre-exposure prophylaxis regimes, and they dropped the 3rd dose. We'd always had 3 doses over 21 to 28 days, day 0, day 7, 21 to 28. But they said, WHO said, you don't need that 3rd dose. 2 doses is enough. 1 intramuscular day 0, a second one day 7. But they also brought in recommended a regime where you could replace your 2 intramuscular doses with 4 ID doses. So 2 ID, 1 into each arm on day 0, and then another 2 ID 7 days later. Now, this was all aimed at reducing the cost of rabies pre-exposure, making it more accessible for people living in endemic countries, but it is a benefit potentially for our travellers as well. The big question does still remain is that 2 doses, if we give 2 doses IM, one on day 0, one on day 7, is that good for life for pre-exposure prophylaxis? And you can see again, there's a lot of variation around the world as to who does accept that and who doesn't. So the World Health Organization says, yes, you only ever need 2, you're primed for life. All you need to do is get your two post-exposure doses. The USA has said it's great for 2 years, but we've got limited data beyond that. So we recommend you need a 3rd dose any time up to within the first 3 years that you've had your first 2 doses. Australia is now saying you need a 3rd dose after a year. Canada is not accepted to the 2 doses. The UK is not accepted to the 2 doses. The Netherlands, Belgium, Thailand definitely have, and some are still saying you need boosters. So, and this is all in the immunocompetent individual. And people who are immunocompromised, it's definitely stick with the old regime, 3 doses, and check for antibodies sometime after vaccination as well. So what's the situation in New Zealand? So we currently have 2 vaccines available, Rabipur and VeroRab. And the Rabipur data sheet has been approved for use as a 3-dose IM pre-exposure prophylaxis, day 0, day 7, 21 to 28, the traditional one. Makes no mention of any of the other ones. On the other hand, VeroRab data sheet has all of these mentioned as approved indications. So the 3-dose IM, 3-dose ID on day 0, 7, 21 to 28, 2-dose IM, and the 2-visit 4-dose ID as well. So if we take the data sheet to say we can do this, then I think we can do it. If we look at the New Zealand formulary, they mention that and saying that you can do the 2-dose IM using both vaccines, but it would be off-label for Rabipur, but on-label for VeroRab. But then they also take this note, for you come down, scroll down, and they say that, for the majority of immunocompetent individuals, 2 doses prior to travel is adequate based on the WHO recommendations. And if a 2-dose regime has been received, and they're visiting an endemic area more than 3 years after the initial 2 doses, a 3rd dose would be required. So they're recommending the American guidelines, and I'm personally moving more towards what the Europeans are accepting, that 2 doses are good for life. But I do accept that this is really confusing and there is some uncertainty still currently in New Zealand. But the good news is we can confidently offer a 2-dose IM prep or 4-dose ID if you are competent in giving ID doses over that day 0, day 7, so over a 1-week pre-exposure course for this trip. They're going to be covered for this trip. It'll be off-label for Rabipur, but on-label for VeroRab. I think you should explain that the World Health Organization and an increasing number of individual countries accepts that either of those 2-visit pre-exposures is good for life, but it's not accepted by all authorities. And if you and they want the reassurance of guaranteed lifelong cover, then get a 3rd IM dose. It's not going to be harmful. The real question at the moment is whether or not it's required. If you are using, however, either of the 2-visit pre-exposure prophylaxis, you must advise that we cannot guarantee that it will be accepted as adequate pre-exposure prophylaxis in the country of exposure. So you just need to prime them and let them know that, so that if they get pushback during their travels, they can say, yes, I understand that. I've been vaccinated in accordance with the 2018 WHO guidelines, and I'm properly primed. I just need my 2 post-exposure doses. So good luck. I hope I've clarified some of the confusion out there. Finally, typhoid. And I come back again to the stephanogram and remembering that that first group up the top are where things that are occurring in between in in more than 1 in 1,000 travelers. The second group, it's occurring between 1 in 1,000 and 1 in 100,000. And the third group down below is between 1 in 100,000 and a million. And typhoid to South Asia comes in at about 1 in 8,000. But the next group down is Africa, Latin America, Middle East, and Southeast Asia. And I think I see a lot of travelers in the travel clinic whose partners, or they've looked it up online, or they've been to see GP, or they've got information online, and they're saying, "Oh, I need typhoid for this trip," and they're going to a resort, they're going to Phuket for a week. They don't need typhoid. Well, it's their choice, but we're talking about, for Southeast Asia, a 1 in 100,000 months of travel for a risk of getting typhoid. And I think it's overused for Southeast Asia. It definitely should be recommended for South Asia. And the Canadian guidelines used a threshold cutoff of 1 in 10,000 risk to say a reasonable person would want to be vaccinated. So, but we do need to bring in some New Zealand data here. So this is data that it's not published, but I've been playing around with it for a few years. A third of our enteric fever comes from India, and 17% all enteric fever, and a quarter, 26% of all typhoid comes from people who've acquired it in Samoa. So we do need, and other Pacific islands featured smaller numbers of travel and not as high. Most of these people were people who had caught typhoid either in India or Samoa were of Indian ethnicity or Samoan ethnicity. This is probably primarily driven by those who are traveling to visit friends and relatives. But you can see the rate per trip to India is 50 per 100,000. The rate per trip is Samoa 23 per 100,000, and Southeast Asia 4.6 per 100,000. So I just wanted to, sorry, just go back to that typhoid slide. Just think a little bit about where you're prescribing the typhoid vaccine for. If you're using the injectable polysaccharide vaccine, we do know from experience with other polysaccharide vaccines that with repeat use, we do get a degree of hypo-responsiveness. There's some evidence of that happening with the typhoid vaccine, but I don't want people paying for a vaccine they really don't need, nor do we want to be using it unnecessarily. We want to keep it for the trips where it's really needed. So India and parts of the Pacific, and long-term trips into Southeast Asia, people working in remote communities and staying for a very long time will be higher risk, but not your average traveler to Southeast Asia. So I was going to finish up on quickly taking you through our qualifications. So if that's whetted your appetite, please come and study with us. Why travel medicine? It's because people are traveling. Where there are risk gradients between home and destination. We know travelers get sick. We know people are traveling well within the incubation period of many diseases. And as I've explained, I hope, in this first half, that there are new and re-emerging infectious diseases and travel health threats. But it is a lot of fun. It's really interesting, especially within general practice, which sometimes can just beat you down a little bit. It's kind of nice to be, dealing with people who are healthy, going off seeking preventative healthcare advice, excited about what they're doing. And I love traveling vicariously through my patients. And we can see that globally we're back to pre-COVID travel volumes. So why come study with us? So our papers are flexible, offer flexible learning. They're designed for busy health professionals to fit this in around your daily life, even if you're working. They're distance taught, all the material is online, you work through it at your own pace. We have online discussion boards and quizzes are held online. We have evening Zoom sessions. Our papers do tend to have 2-day block courses. There's a choice of joining us here in Wellington or joining remotely via Zoom. And if you can't make it to the block courses or to the evening Zooms, we record everything and they're available throughout the semester on the web-based learning system. For wilderness and expedition medicine, the residential is compulsory. We have 4 days up on the Tongariro National Park on the plateau, and you do have to attend that one in person. We've been delivering our travel medicine qualifications now for 25 years, and they've always been distance taught. So we're not new to distance teaching. We've got a great team of teachers. Myself, I've helped with Claire Wong, who's a nurse who's done a lot of travel medicine, helped set up the NATHNAC site in the UK, and Sean Council, who's helped me out on the tropical infectious diseases paper and wilderness medicine for a long time. Our qualifications remain the only postgraduate travel medicine qualifications in New Zealand and one of only 2 qualifications in Australasia. And if you're interested in becoming an authorised yellow fever vaccinator, then the regulations require that you have postgraduate training in travel medicine. And if you do our certificate, that fulfills that requirement. A point of difference, all our papers are open to all healthcare professionals. So we have interprofessional learning and teaching. Your class will include GPs, primary healthcare nurses, other nurses, nurse practitioners, pharmacists and paramedics. And your teachers will also come from many different professions, which helps build up our team and allow us to deliver better travel medicine. If you haven't studied for a while, this is a concern often to adult travellers adult students coming back to university after some time. Don't panic. You won't be the only one. Many of our students have not written an academic essay or sat an online quiz or participated in study for a long time. We do have study skill resources that are available online. Our librarians are wonderfully supportive in helping us. We believe that the online platform is reasonably easy. It's pretty good to use. And we're getting a new one next year, which should be even better. We have a student learning advisor who can help you with draft essays and other learning support. There's disability support through the university. And also when you're coming in as adult learners, you bring a wealth of clinical experience, which just makes getting through the papers so much easier as well. So how are they structured? We have the postgraduate certificate, which is the 2 core papers, and most people enroll and do that certificate spread over. Sometimes they do 2 papers in 1 year, one in semester 1, one in semester 2, finish it in 1 year, or do 1 paper in 1 year and come back the next year and do the next paper. Having done the 2 core papers, you then, the 3rd core paper is tropical infectious diseases, and then you can bring in an elective paper as well. And some people go on to do a master's in travel medicine. The core papers, there's Travel Medicine 1, which concentrates very much on the pre-travel consultation and vaccine preventable diseases. Travel Medicine 2, which is food, water and vector-borne diseases and post-travel. And then 719 is tropical infectious diseases, looking at those tropical diseases in much greater depth and how you would manage them both in New Zealand and in endemic countries. The elective papers, there's wilderness and expedition medicine, which is looking at the impact of environment on travellers and outdoor enthusiasts, extremes of temperature, altitude, and the challenges of delivering medical care in the outdoors, and including a bit of work around, we spend a lot of time talking about the challenges of being the expedition medic. And then refugee migrant health paper, also very popular paper, which talks about managing the health needs of refugees and migrants coming into New Zealand and the resettlement processes and policies. Our department does also offer qualifications in New Zealand in primary health care. All of these papers can be used towards the travel medicine qualification, but there are also primary healthcare qualifications as well. The two core papers are the PHRC 701 and 703, and then there's also sexual and reproductive health, which many people also use towards their travel medicine quals. So in summary, you can study when and where it suits you. You gain a highly respected qualification in travel medicine. You'll get lots of benefit from working and learning in an interprofessional environment, and you'll bring research-informed thinking to the delivery of travel health care. And you'll learn from a great teaching team and receive lots of support from us and the university. So have a look also, we've put together, interviewed myself and a former student talking about travel health in a changing world. If you if you need any more information, please feel free to email Courtney on our admin support on the travel medicine at otago.ac.nz, or email myself at jennyvisser@otago.ac.nz. While I have you all captive, I just want to put a little plug in for the New Zealand Society of Travel Medicine Conference, which is just a month away. We're holding it in Christchurch over the 7th to 9th of November. The keynote speakers are David Schlim from the USA and Sarah McGuinness from Australia, both superb speakers. We've got a great program, and if you want to register, then please go ahead and check on, go to the registration site, or if you're having any difficulties, please email me and I'll